in emergency. So these are the disorders of flow of thought and particularly the tempi. So what did we learn here is in the disorders of flow, the disorders of tempo are one passenger losing the tempo
I think
on
I'm
a
audible and
flight.
visible now.
Then there came a circumstance, so circumstantiality,
Yeah, you can see
where
my
he started
irritated
using the
face.
slang or the clang
Was trying
language
since
and
slog,
the
but it
pilot
was
had
not
to
working.
retard
Finally,
the
it is
flight.
there.
Okay, so the
Try till
retardation.
you succeed, and I
The
think we have
next one are
succeeded.
the
Yes.
disorders of continuity, where the continuity of the thought is affected. So perseveration and thought block. Block itself tells you that it's blocked, it's not going ahead. So disorder of continuity, so the river is not continuous, the flow is not continuous. So disorder of flow of
क्या हो गया
thought.
voice को?
And perseverance, matlab
Is there an issue
sticking
with the
to that
voice, with the
one
audio?
activity, that is what we say, be perseverant. But here this is a thought disorder where the patient is perseverant about that one thought. So it is continuity. So the flow is not happening, right? So remember that these are the disorders of flow
Abhi
of
also it is
thought
echoing.
or the stream of thought. Next is the form of thought. So the story here is
Is
this
there still an
is
echo?
basically a new contest that has been announced in our area.
Third
So
disorder
all
चल
of
जाता है
us are
क्या? ऐसा तो
excited to
कुछ
fill
चालू
up
है.
the form for that. So this is the form
Abhi is
that
it
we
fine?
need
I've
to
tried
fill
to
up for
close
the new
everything.
contest. What is the new contest? So in the new contest, what we have to do is basically this is the road, the track of the railways. The competition is we have to walk tangential to this track without losing the balance. So the one who does this basically will win. Now what happens is we participate in this contest, we fill up the form and we participate in this contest and we are walking tangential to this. But when we are walking, some of us, we cannot control
Is
our
the
hunger.
background voice still
Even
there?
during the
I don't know.
contest, we are like, we are very, very hungry. We cannot wait now. Please give us salad. So some of us start eating salad. And because we eat salad, we lose our balance. And that is why we lose the
Psychiatry class
balance.
कहाँ
We
से?
get derailed and we lose the contest also.
Let me
Right?
check.
So the
Yeah, I think you guys had pre-exam hallucinations, auditory hallucinations. अभी कुछ आवाज नहीं आ रहा है ना? अभी better है? I was just kidding. So I hope now you can hear me and see me well, everybody. Finally, we are here. Nice. अभी double आवाज आएगा. Yeah, because long time na Srishti have not taken a YouTube live class, तो सब कुछ भूल चुके हैं. Have been used to taking classes live on the Medsynapse app now, so I've forgotten the YouTube live settings, everything. Right, this class, this video will be available till tomorrow. After that, it will be available on the app, the Medsynapse app. And for everybody here, this is part 2 of the pharmacology binge revision, as the thumbnail also says. So if you're wondering ki part 1 ka hai man, part 1 to hua hi nahi. So part 1 we had done yesterday on the Medsynapse app. Right, so you can watch it there on the Medsynapse app, the part 1 of the binge revision. ठीक है, हाँ बहुत लंबे टाइम बाद YouTube live हो रहा है. So starting with this, guys, a quick revision of what we have seen yesterday. I hope you remember kal kya kya dekha tha when we had the in-app live class. We had seen the general part, bioavailability, and these curves that have been asked. What is spurious drug? What is misbranded? What is NDA? What is IND? Then we had seen cholinergic के effects क्या होते हैं, adrenergic के effects क्या होते हैं, and we had seen this mnemonic जिसका किसी का loudspeaker भी on था कल, right? और उसके बाद हमने कुछ glaucoma drugs के कुछ points देखे. We saw the cardioselective beta blockers, then some side effects and contraindications, diuretics, valproate, opioids quickly देखा था, buprenorphine, butorphanol, pantazocine कैसे differentiate करते हैं. How do you remember that? Right, we had also seen about alcohol and smoking de-addiction, some drugs in Alzheimer's, right? Methylphenidate, modafinil, where are they used? Then we had seen some teratogenic effects, right? And then we were at the antiretroviral drugs, skin pigmentation, nail pigmentation, that has been asked in the exam, cyclophosphamide. Then we had seen the endocrine drugs, 5-alpha reductase, SGLT2, sildenafil dekha tha, immune checkpoint inhibitors dekha tha, right? I hope you remember the mnemonic dal and put Nivea cream, right? So that we had seen, and we had seen some anti-cancer monoclonal antibodies, alemtuzumab, bevacizumab, bevofarani, and all of that. And yes, we had seen the immunosuppressants, calcineurin inhibitors, nephrotoxic, cyclosporin, tacrolimus. We had seen mycophenolate, azathioprine inhibiting the purine nucleotides. And we had seen sirolimus, where the kidney survives. It is not nephrotoxic. It acts on mTOR, right? All these points we had seen yesterday. This table of the immunosuppressants that we had seen. Basiliximab dekha tha, interleukin-2 receptor alpha, daclizumab is also belonging to that group. And we had seen this recombinant cytokines. Where do you use interferon alpha, beta, gamma? What is oprelvecin, romiplastim, filgrastim, sargramostim, all of that. So that is what we had seen yesterday. And today we plan to do the rest of the thing. Yes, Dr. Renu, you should definitely be doing that. As a nahi hai ki the NEET PG students should not be doing the I9CT topics. Please don't do that. You have to do those topics as well. Today, according to the timetable that we had, the binge revision that is going on. So far we have completed biochemistry, pediatrics, pathology, PSM, physiology, pharmacology we are completing today. Actually, according to the timetable today, we had microbiology binge revision to be done. But because pharmacology was remaining, so we'll do pharmacology today. Microbiology and FMT, we'll do both of these tomorrow, right? That is going to happen in-app live for the subscribers. So tomorrow we will have microbiology and FMT, both of that, 12 p.m. and at 3 p.m., right? Because like I mentioned, like tomorrow I'll have to finish the classes in the first half. So we will do that at 12 noon and 3 p.m. microbiology and FMT. Microbiology actually I had prepared for today also. And so we are going to discuss in the tomorrow's class the mnemonics for bioterrorism agents, the mnemonics for biosafety levels, the incubation periods, what is prozone phenomenon, post-zone phenomenon, the mnemonics for your Audine, Oakley, Octerlony. And very, very important, I9CT ka favorite hai, giving you the images and identify the organisms, be it bacteria, be it virus. How do you identify from the image and the important points related to that? So all of that we are going to see tomorrow. So 12 noon and 3 noon we'll have microbiology and FMT. Okay? Right, so this was about this. So starting with the part 2 of the binge revision of pharmacology. So this is very, very important for your exam. Apart from this, you should also be watching the video of the new drugs, which is available both on YouTube and in app. Please watch that video. It's very, very important for your upcoming I9CT exam. So let's quickly discuss. Right, so let's quickly discuss the other antibodies that are, these are basically your fast snippets also. So these are given in your first aid book, and that is why these are very much expected in your exam also. So which are the TNF alpha inhibitors, the monoclonal antibodies? I hope you guys remember the mnemonic, इटली की अदालत में क्या देके क्या सर्टिफिकेट देके इंसाफ होता है? गोल्ड सर्टिफिकेट देके इंसाफ मिलता है, right? So in Italy ki adalat, insaf is given by the gold certificate. Italy is etanercept. As the term says, etanercept is a receptor. It's a decoy TNF alpha receptor. It's not a monoclonal antibody per se. The rest of the maps, adalat is adalimumab, gold golimumab, certolizumab, infliximab. All of these are TNF alpha drugs. Out of these, if you see the XI helps you to remember that this is a zymeric, that is a chimeric monoclonal antibody. Infliximab is zymeric, that is chimeric. So these are used in various conditions where you want to inhibit the TNF alpha. We know that TNF alpha pro-inflammatory hai. So inflammatory bowel disease, rheumatoid arthritis, psoriasis, ankylosing spondylitis. But very, very important, remember that before giving these drugs, we need to test for TB and other viral infections because there's a risk of reactivation. Remember, TNF alpha and interferon gamma are important in maintaining the granulomas, right? So TB and viral infections need to be pre-tested because it can get reactivated. Next one, very, very important, eculizumab. Remember, EC is like 5C. E is the fifth alphabet. 5C, that is C5 complement protein. So it acts against the C5 complement protein, and by that it inhibits the complement overactivation, which is seen in PNH. What is the deficiency in PNH? The CD55 and CD59, which are your decay accelerating factor and MAC inhibiting factor. So when they are deficient, the complement becomes overactive. So we give eculizumab. Remember, when you are inhibiting the C5, that means you are leading to that membrane attack complex, the terminal complex deficiency. So what risk will increase with that? Very, very important. C5 to C9 deficiency, the terminal complement deficiency is recurrent. Neisseria infections, right? This is very, very important. So meningococcal infection risk will increase with eculizumab. Now coming to the drugs which are used in psoriasis, look at this one. Interleukin 23, interleukin 17, and you have both interleukin 12 and interleukin 23 acting drug. So which is the drug which is acting on both? Okay, so remember that interleukin 12 और interleukin 23 दोनों interleukin को inhibit करने वाला drug is a ustad drug. Okay, this is a ustad drug, right? क्या ustad क्या बात है? Inhibiting two interleukins. So remember, ustad drug, ustekinumab is a ustad drug inhibiting both 1, 2, 2, 3, 12 and 23. While your ixekizumab and secukinumab XE or SE are inhibiting interleukin 17. Okay, they are inhibiting interleukin 17. So XE/SE is interleukin 17. While guselkumab is interleukin 23, right? So everyone here, you must be around the age of 23, right? और बहुत गुस्सा भी आता है. So remember, गुस्सा आता है at what age? At interleukin 23, age 23. So remember, it is 23. Okay, so it is interleukin 23. So 12, 23 and 17, these are used for psoriasis. Next one, you have alpha 4 integrin wale drugs. Both of these are alpha 4 integrin. One is natalizumab and one is vedolizumab. Okay, natalizumab and vedolizumab. Natalizumab is used for multiple sclerosis and Crohn's. Very, very important. It has a risk of PML in patients with JC virus, progressive multifocal leukoencephalopathy. So you need to test for JC virus antibody before giving natalizumab. So remember, this JC virus basically falls under polyoma virus. You have JC virus and you have BK virus. JC affects the cerebrum, that is the brain, the leukoencephalopathy, and BK is kidney transplant wale patients. Okay, so this is seen with kidney transplant. So JC is cerebrum, BK is kidney, and natalizumab is your multiple sclerosis drug reactivating JC virus. While your vedolizumab is particularly used in IBD. Okay, this is used in inflammatory bowel disease. This is gut-specific anti-integrin. So it prevents the leukocytes coming to the GIT. Vedolizumab, alpha-4 integrin inhibitor in the gut. Okay, it is in the gut. Denosumab, remember, denos is os. That means it is used in osteo condition, that is osteoporosis. What does it inhibit? It inhibits the rank ligand. So it inhibits the osteoclast maturation. So what is it mimicking? It mimics your osteoprotegrin, which activates, which matures your osteoclast. So how is this acting? By inhibiting the resorption, which is the osteoporosis drug which stimulates the formation, right? A surprising activity that is has, action that is had. O-theory. What is O-theory? Teriparatide. Teriparatide is bone forming. Okay, that is bone forming. So remember, denosumab makes the bones dense by inhibiting the resorption, osteoclast maturation. It mimics osteoprotegrin. Emicizumab, remember the term CI helps you to remember that this is used in circulation. Okay, this is used in circulation. So EMI helps you to remember this is factor 8 mimicking drug. Okay, this is factor 8 mimicking drug. So if it is factor 8 mimicking, where will I use it? We will use it in hemophilia A. What does factor 8 bind to? It binds to your factor 9 and factor 10. So remember, this is mimicking factor 8. It is bispecific. It binds to both factor 9 and factor 10. It is used in hemophilia. Do not confuse Emicizumab with Eculizumab. Eculi is EC, that is C5PNH. MEC is 8 mimicking factor. That means it is your hemophilia A. Okay, hemophilia A. Very, very important. Right. And which is the other drug that we use in hemophilia A? Hemophilia A is factor 8. Factor 8 stabilizing factor kaun sa hai? That is von Willebrand factor. What is the role of von Willebrand factor? Platelet adhesion. Okay, that is platelet adhesion. So which is the drug which stimulates the release of von Willebrand factor from the endothelium? That is desmopressin. Okay, that is desmopressin. So remember, desmopressin is used in von Willebrand disease and hemophilia A. Guys, do you remember from a pathology binge revision, hemophilia A versus von Willebrand disease? What will be the difference in the lab studies? कहाँ पे BT बढ़ेगा, कहाँ पे APTT बढ़ेगा, PT बढ़ेगा, क्या होगा दोनों में? Remember, hemophilia A is your intrinsic factor. The mnemonic is happy. APTT in intrinsic factor, so the APTT increases. Von Willebrand is for platelet addition plus factor 8. So platelet wala BT बढ़ेगा plus APTT बढ़ेगा. Very, 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 very important. Okay, very, very important. You have to remember this. Von Willebrand factor is both. Okay, BT and APTT. Coming to next one, Omalizumab. OMA is the mast cell related. Where do you have the role of mast cells in asthma? Which immunoglobulin in asthma? It is IgE. So this is used in refractory allergic asthma. It prevents the IgE binding to its receptor on the mast cell. Mast cell has the receptor for IgE. Again, a previously asked question. Palivizumab, the VI tells you that this is used for some virus. Which virus? Prophylaxis of which virus? It is respiratory syncytial virus, which causes bronchopneumonia in neonates and infants. Right? So this is used for prophylaxis for high-risk infants, RSV, respiratory syncytial virus, palivizumab. Is this clear with everyone? Right? So this is like a must-know monoclonal antibodies. This is like must-know for your NEET PG exam also. Apart from that, like I said, please watch the new drugs. The video is there both on YouTube and on Medsynapse app also. Okay? Right? Let's go to the next part here. Let's go to the next part. Yes, ribavirin is for treatment. Palivizumab is only for prophylaxis. Coming to SERMs, selective estrogen receptor modulators. Which are those? Clomiphene, tamoxifen, and raloxifene. Okay, clomiphene, tamoxifen, and raloxifene. So all the fen are your SERMs. Okay, they are your SERMs. Fen. So clomiphene. Where does clomiphene act? Very, very important. Remember, is it acting in the ovary, in the anterior pituitary, posterior pituitary, or in the hypothalamus? Where is it acting? So please remember, it is acting in the hypothalamus as an antagonist for the estrogen receptors in the hypothalamus. Very, very important. It is acting on the hypothalamus. So by not allowing that estrogen to act on the hypothalamus, it is preventing the negative feedback, the normal feedback inhibition, and that's how it increases the LH and FSH from the pituitary, and that's how it stimulates the ovulation. So please remember, it is antagonist at hypothalamus, very, very important. So it is used in PCOS where there is anovulation, the side effects that you get here, hot flushes, ovarian enlargement, right? OHSS that can come, and visual disturbances. Okay, and visual disturbances. Tamoxifen we use in breast cancer. So logically thinking, if it is used in breast cancer, in the breast it will be antagonist or agonist. So it is not allowing estrogen to act on the breast. So remember, it is antagonist at the breast, but at the uterus, at the bone, it is agonist. So it causes the growth in the uterus, and that is why what can it cause? It can cause endometrial cancer. And that is why, do we give it in premenopausal or postmenopausal? Postmenopausal already having increased risk of endometrial CA. So we will not give it in postmenopausal, right? So what do we give in postmenopausal? We give aromatase inhibitors, right? We have discussed this in short, available on the Medsynapse app also in surgery, right? So it is not used in postmenopausal. So the side effect that it can have, there is increased risk of thromboembolic events, like similar to OC pills. जब आप estrogen देते हो thromboembolic events बढ़ जाएंगे, endometrial cancer बढ़ जाएगा. Okay. Next one. So reloxifan. How does reloxifan helps us to relax? Remember, it helps us to relax in terms of endometrial cancer. It does not cause endometrial cancer because it is antagonist at both breast also and uterus also. But the good part is it is agonist at bone. So therefore, what is it used for? It is used for osteoporosis. Okay, it is used for osteoporosis. So it is primarily used to treat osteoporosis. But still, because it's an estrogen wala, it has increased risk of thromboembolic events. It has increased risk of thromboembolic events, but no endometrial cancer, remember that. So you can relax with reloxifan. No cancer, but thromboembolic events will still be there. So remember all the SERMs that we saw, right? They can cause your even tamoxifen, reloxifan, both of them can cause thromboembolic events. FENS are your SERMs. Aromatase inhibitors, what does aromatase do and where is it present, guys? What is the role of aromatase? Basically, it converts testosterone to estrogen. And in the ovary, where is this aromatase present? The granulosa cells. Okay, that is the granulosa cells, which is under the control of, this is inhibin here, which is coming. Granulosa cells, inhibin, FSH, right? Again, this has been discussed in physiology short, right? So remember that the aromatase inhibitors are the zoles, trozols, and nestrozole, letrozole, or exemestane, even exemestane. So trozole is testosterone to estrogen zero conversion. It is making the testosterone to estrogen conversion zero. So anastrozole, latrozole, and even your T2E, TANE is antagonizing testosterone to estrogen. So even exemestane is your aromatase inhibitor. We use this in postmenopausal females because we cannot use tamoxifen there. It prevents the conversion of androgens to estrogens. Your previous AIIMS exam question, what is the half-life of letrozole? Just remember, it's a one-line factual question, 45 hours. Remember, these are the type of questions in the exam where you have not read, so you don't know, so you leave those questions. These are the type of questions which you do not attempt. Otherwise, even if you know a little bit about the topic, you have to attempt those questions, right? Such questions are to be left. Okay? Yes. Tamoxifen should be stopped at least like 3 months prior to conception. 3 months prior to conception. Okay? Right. Best is 2 years. Okay, Dr. Sushmita. Coming to next one, the next frequently asked topic in your AIIMS exam. Again, the sickle cell anemia is their favorite topic. Sickle cell anemia, they've asked the mutation. We have discussed in biochemistry. It is point mutation, missense mutation, beta-6 glutamate to valine, and it is autosomal recessive, right? It has the chest syndrome, the dactylitis. Those are the classical symptoms that are given in the question. So sickle cell anemia, another question we discussed in pathology. What was that? How is the mechanical fragility and how is the osmotic fragility of the sickle cells? High mechanical, low osmotic fragility, right? Spherocytes have high osmotic fragility. So the drugs used in sickle cell anemia are hydroxyurea, voxelotor, and L-glutamine. Hydroxyurea, remember hydroxy, hydrogen, reduction. It acts by inhibiting ribonucleotide reductase. It acts by inhibiting ribonucleotide reductase in cancers. In sickle cell, it acts basically by decreasing the polymerization and the precipitation of HbS. Okay. Now, this is the image to help you remember voxelotor. What is voxelotor? So what happens in the sickle RBC is when the hemoglobin becomes deoxygenated, this HbS gets polymerized and it causes the hemolysis, the breakdown of the RBC. So what is voxelotor doing is, even after deoxygenation, it is not allowing the sickling. So this drug is acting by preventing the polymerization of HbS in the deoxygenated state. So remember, this is voxelotor. Voxe, VOX, something related to oxygenated or deoxygenated hemoglobin. It prevents the polymerization of HbS in the deoxygenated, and that's how it prevents the hemolysis. So remember, an L-glutamine is your like antioxidant जैसा function, even that prevents your polymerization. ठीक है? Clear with everyone? Right, so this is voxelotor is important, that is sickle cell anemia. Coming to the next important topic that is asked frequently in the exam, arachidonic acid, phospholipase, arachidonic acid, cyclooxygenase and lipoxygenase. So basically talking about these drugs here. So remember, in the membrane we have phospholipids. So the enzyme acting here, phospholipase A2. Again, do you remember from pathology, phospholipase A2 receptor antibody is present in which nephropathy, guys? Membranoproliferative, FSGS, membranous. Where is it present? PLA2 receptor antibody is present in what nephropathy? It is membranous nephropathy. Okay, this is membranous nephropathy. That's how we remember. In the membrane, there is phospholipid, so phospholipase A2, right? I hope all of you remember that. So phospholipase A2, when it breaks down the phospholipids, we get arachidonic acid. Okay, we get arachidonic acid. So remember, an arachidonic acid, then via the enzymes acting here, cyclooxygenase 1, cyclooxygenase 2, and we have lipooxygenase, COX and LOX. So when there is COX acting, you get the cyclic endoperoxides, right? Like prostacyclin, cyclic endoperoxide. So you have prostaglandin, prostacyclin, and you have thromboxane also coming from here. Remember, these prostaglandins has been asked in the exam. They have this 5-carbon ring. Prostaglandins, they have the 5-carbon ring, right? Now, thromboxane A2, as the term says, it will be thrombosis related. So it increases the platelet aggregation and increases vascular tone. So that is why when we inhibit cyclooxygenase by aspirin, aspirin has this anti-platelet action by inhibiting cyclooxygenase. Okay. In the prostaglandin, you have prostaglandin E1, E2 and F2 alpha. So E1 is L-prostadil and also misoprostol is also E1. So you can remember this as E1 is PG. E1 is play game 1. Okay, play game 1. That is prostaglandin. E1 is A and M, L-prostadil and misoprostol. Okay. What is L-prostadil? Remember, what is prostaglandin E used for, guys? Remember, it opens the ductus arteriosus. So it keeps the ductus arteriosus open, like we need in transposition of great arteries. Next one is PGE2. Remember, di is 2. So this is ending in E and it has di. So this is prostaglandin E2 dinoproston. Dinoproston. So it increases the uterine tone. Carboprost, letanoprost, all these are prostaglandin F2. Ending in prost are F2. Right? Carboprost is related to your obstetrics, while letanoprost is used in glaucoma. Okay, letanoprost is used in glaucoma. So what is the one? Thromboxane is acting on platelet aggregation increasing. The other one which decreases the platelet aggregation is PGI2, which is prostacyclin, PGI2. So you can remember this as PGI2 is platelet gathering inhibitor, Which prostaglandin is platelet gathering inhibitor? It is PGI2. Which is the PGI2? Epoprostenol. Okay, that is epoprostenol. You can write it as EPO. Okay, this is I. Epoprostenol is PGI. And it decreases the vascular tone. So PP, it is used in primary pulmonary hypertension treatment. Epoprostenol, and also the other I, that is iloprost wala. Iloprost also. Dinoprost is going to be PGF2 alpha because it's just prost. Okay, it is just prost. Okay? So remember, this is for prostaglandin E1, E2, F2 and PGI2. Okay, and PGI2. Right? So prostaglandin platelet gathering inhibitor is PGI2. It is used in treatment of pulmonary hypertension. Now coming to when the LOX acts on arachidonic acid, L for L, LOX will give leukotrienes, leukotriene B4, C4, D4 and E4. Out of that, very, very important, which is the leukotriene which is responsible for neutrophil chemotaxis? So remember, this is your leukotriene B4. All the compound substances which are chemotactic. Remember which interleukin we have discussed, cytokines, interleukins with mnemonics in pathology binge revision. Which one? Which one opens PDA meet? It is your alprostadil OPE, opens prostaglandin E. Iloprost is again your I. Okay. So remember, interleukin kaun sa dekha tha? 8. One circle and two circle coming together, attracting to each other. So imagine like these are the chemotactic coming together. Next one, interleukin 8, leukotriene B4, and which is a complement, which is the chemoattractant. It is, which complement is chemoattractant? C5. Okay. So remember here, what are we seeing here is C4, D4, E4, what do the leukotrienes do? They increase the bronchial tone. And that is why we use the inhibitor drugs, that is montelukast, zafirlukast. These are the receptor antagonist. Ast is receptor antagonist. While ziluton is synthesis inhibitor. Ziluton is acting on lipooxygenase. Xyluton is synthesis inhibitor. It inhibits the synthesis lipooxygenase. Please remember that. Okay. Right. So this is about your drugs. And remember your coxib drugs like celecoxib. All your coxib drugs are COX-2 selective inhibitors. Selective COX-2 inhibitors. Right? Like your celiprolol is beta-1 selective. Celecoxib is COX-2 selective. Okay. And aspirin, important, is the irreversible non-selective inhibitor of COX-1 and COX-2. The rest of them are the selective inhibitors. Okay, the rest of them are reversible inhibitors. Diclofenac, ibuprofen, indomethacin, ketorolac, all of these are reversible. Okay, all of these are reversible. Which are the drugs which act on the phospholipase A2, inhibit the phospholipase A2? Remember, glucocorticoids. And that is how glucocorticoids have anti-inflammatory action. Because they are not allowing the arachidonic acid and then your prostaglandins or leukotrienes to come in. And that is how glucocorticoids are anti-inflammatory by acting on phospholipase A2. Right? Another question that has been asked, the phospholipase C acts via GQ. What is GQ wala? It is IP3DAG increasing the calcium. So remember, the GQ wala GPCR is your IP3DAG calcium. So IP3 comes from the phospholipid, the cell membrane. Inositol, triphosphate, diacylglycerol, all this is coming from phospholipid. So phospholipase is your GQ. Okay, phospholipase is your GQ. Clear with everyone? This is very, very important, right? This is again your fast snippet. Coming to next important question that has been asked in the exam, acetaminophen, that is your paracetamol and aspirin. The question that has been asked here is NEETPG. So you can see how this chota word in first aid is actually your question in the exam. NEETPG comes during the metabolism of paracetamol. So overdose, it produces hepatic necrosis. Remember, paracetamol affects the liver. The metabolite of acetaminophen, NEETPG, it depletes the glutathione. And that is why, what do we give as the antidote for paracetamol? N-acetylcysteine, which will regenerate glutathione. I hope you remember from biochemistry, glutathione is GCG, glycine, cysteine, glutamic acid. So cysteine is required for glutathione. So we give an acetylcysteine. Paracetamol, remember, is a reversible inhibitor of cyclooxygenase. In the periphery, it does not act. So that is why predominantly it has antipyretic and analgesic action, but not anti-inflammatory. In the brain, causing antipyretic, analgesic, but not anti-inflammatory. And where do we prefer using paracetamol? In Ray's syndrome. What is Ray's syndrome? Because of aspirin. Right? So children with viral infection, when given aspirin, they get this Ray's syndrome. So do not give aspirin there. You give paracetamol there. Okay? Ray's syndrome, aspirin. Remember that. Next you have aspirin. Aspirin important is IR, irreversible inhibitor of cyclooxygenase, both 1 and 2. Why irreversible? Because it is causing the covalent modification, that is acetylation. It decreases the synthesis of thromboxane also, right? And that's how it has the effect on your bleeding time. So it increases the bleeding time, but no effect on the coagulation factors. In low dose, it is decreasing the platelet aggregation, right? So remember, for platelet aggregation, it is low dose action. Very, very important. Remember that aspirin toxicity will present with tinnitus. There will be tinnitus in aspirin toxicity. Gastric ulcer tinnitus, right? And what is that triad where there is aspirin sensitivity? Remember Samter's triad, again something we have discussed in ENT. Samter's is Santer's triad. What is Santer's? There is sinusitis, aspirin sensitivity, and there is nasal polyposis, asthma. So patients with asthma or nasal polyps, here you should not be giving aspirin. Okay. Remember, it can lead to interstitial nephritis, Ray's syndrome important, toxic doses, respiratory alkalosis, because it stimulates the respiratory center. It's a salicylic acid, so then it will lead to metabolic acidosis. Overdose treatment, important, has been asked recently. What do you give for aspirin? You give sodium bicarbonate. Why? Because aspirin is like salicylic acid. It's an acidic drug. So you give a base alkali when you have acidic drug cut toxicity. Aspirin is acidic, so causes metabolic acidosis. So you give bicarbonate, very, very important. Please remember all these points. Yes, it causes hagma. Okay. Coming to the next important topic here, guys. Let me know whether all of you are with me. You've understood all the points that we have discussed so far. Each of them is very, very important for all your upcoming exam. NEET PG ho, FMGE ho, ya AIIMS ho. Very, very important. Right? Can we go on to the next one? Give me a quick thumbs up, everyone. Okay, that's great. So going to the next one, the cell wall synthesis inhibitors. Okay, the cell wall synthesis inhibitors. We have already discussed this, but just to reinforce, because this is asked very, very frequently. What antimicrobial acts on chain elongation inhibitor and what antimicrobial acts on cross-linking? What antimicrobial acts on chain elongation? Remember, chain elongation inhibitor drug is vancomycin. इधर क्या हो गया? Pharmacology. Okay, that is vancomycin. हाँ, और क्रॉस लिंकिंग वाला कौन सा है? बीटा लैक्टम्स, including your imipenem वगैरह, the monobactams and beta lactams. So how did we remember this? Is we have discussed in short again. Van is a long car. So remember, van is a long car. So elongation is vancomycin. Beta lactams is cross-linking. Beta lactams is cross-linking. What enzyme causes the cross-linking? Cross-linking one peptide chain to other peptide chain. So it is transpeptidase. Okay, it is transpeptidase. That is how other question can be asked. And what is the mechanism of action of MRSA? It is the altered penicillin binding protein. Methicillin resistant staph aureus, you have altered penicillin binding protein. So you are given this image. So remember, this is where the chain is elongating. So this is where vancomycin acts. This is the cross-linking which is happening between the two peptide chains. So remember, this is beta-lactam antibiotics here. This acts on cross-linking and this acts on elongation. Other drug cell wall synthesis inhibitor is beta, asking for all the vehicles, right? Ford de do, cycle de do, bus de do, van de do, and beta. What is beta? Beta lactam. So beta asking for all the vehicles from the dad. Cycle, bus, Ford, van. All these drugs are cell wall synthesis inhibitor. But please remember, very, very important, if you get a question that which of the following antibacterial drug acts on the cell membrane, not on the cell wall, then what will be the answer? Cell membrane, cell wall nahi. The question is cell membrane, so read that very carefully. So it acts by causing the cell membrane depolarization. Can someone tell me what drug is that which causes the depolarization? Yes? Very good, Rashi, Srishti, absolutely right. It is depolarization, DAP. Remember, DAP is daptomycin. Daptomycin acts by causing the cell membrane depolarization. It is daptomycin. Okay, daptomycin, important. Right, going to the next one, which is neurodegenerative disease therapy. So we'll be talking about Alzheimer's. We have seen this already yesterday. A quick revision. Acetylcholine esterase inhibitor drugs are the drugs which guard us against Alzheimer's. That is donepezil, rivastigmine, and galantamine. Out of that, rivastigmine is the one which is available as a patch. So if the patient cannot take oral, we can give rivastigmine. These are the first line treatment. In moderate to advanced cases, you can give memantine alone or in combination with acetylcholine esterase inhibitor. Memantine, MMNNM, this is the one which is NMDA antagonist. So it helps prevent the excitotoxicity which is mediated by calcium. Okay, which is mediated by calcium. Next one, what do we have here is this is important. ALS में कौन सा ड्रग यूज करते हैं और हंटिंगटन्स में कौन सा ड्रग यूज करते हैं? So remember, ALS में यूज करते हैं रिल्यूजॉल और दूसरा ड्रग कौन सा है? इडारावोन. Okay, the other drug is idaravone. So riluzole and idaravone, that is used for ALS. Okay, that is used for ALS. And these act by decreasing, riluzole decreases again the glutamate excitotoxicity. Remember, riluzole, your ALS is both upper motor neuron plus lower motor neuron disease. It affects both upper motor neuron and lower motor neuron. Huntington's disease, Huntington's chorea. Remember, Ben wala drug, benazine, or it is Benz wala, benazine. So remember, tetrabenazine. Okay, tetrabenazine or deutetrabenazine. So remember, Huntington goes for hunting in a boxcar. It has boxcar ventricle. So this boxcar, you can remember, this boxcar has tetra wheels. Okay, tetra wheels. It is like a Benz. This boxcar is like a Benz, Mercedes-Benz, which has tetra wheels. So remember, this tetra-benz wala drug is used for Huntington's. Tetra-benz. How does it act? It acts by inhibiting the transporter, the VMAT, vesicular monoamine transporter. So remember, this boxcar is transporting wala drug. So boxcar mein wo transport ho raha hai. So remember, it is VMAT inhibitor. So it decreases the dopamine release. It decreases the dopamine release. In Huntington's chorea, CAG, repeat, what is decreasing? Acetylcholine and GABA. तो हमको क्या करना है? साथ में dopamine भी कम कर दो as a treatment. So we give this VMAT inhibiting drug in decreasing the dopamine release. So remember, this is tetrabenazine. And we have also seen that valbenazine, tetrabenazine, this is used for tardive dyskinesia also. Right? TV, valbenazine. Tardive dyskinesia, valbenazine, tetrabenazine. Is this clear with everyone? Yes. Huntington Benz की car है यहाँ पे. Right, like a Benz which has the tetra wheels. Remember, it is transporter inhibitor, decreasing the dopamine release. Okay, decreasing the dopamine release. Right? Alzheimer's के कुछ important points which I wanted to highlight here. Remember ApoE4 and ApoE2. ApoE4 increases the risk. ApoE2 decreases the risk. So remember, 2 is a chota number, 4 is a bada number. So 4 upar, 2 niche. So 2 decreases, 4 increases. Where is this present? On chromosome 21. The amyloid precursor protein, it is present on chromosome 21. And that is why in Down syndrome, you have early onset Alzheimer's. Okay. And remember that your beta amyloid and the neurofibrillary tangles. Important to remember, the senile plaques containing the beta amyloid, they are extracellular. Okay, they are extracellular. While your neurofibrillary tangles, they are intracellular. Okay, they are intracellular. So amyloid, आपको पता है amyloid extracellular eosinophilic होता है. So remember, the beta amyloid is extracellular, neurofibrillary intracellular. The neurofibrillary tangles are your hyperphosphorylated tau protein. Okay, this is tau protein that you have. What bodies can you get in the hippocampus? HI, Hirano bodies. Okay, these are Hirano bodies in hippocampus. Remember, hippocampus has a role in the memory, and that's how it is affected in Alzheimer's. Hippocampus is affected. There is cortical atrophy, especially of the hippocampus. Is this clear with everyone? So look at this one. Something which is extracellular here. This is amyloid. What stain do we use here? Black color. Bilshowski, right? Bilshowski stain is used here. And you have the intracellular neurofibrillary tangles, which are intracellular. So tangles are intracellular, amyloid is extracellular. So remember, this amyloid can also cause amyloid angiopathy, which will classically have elderly may recurrent hemorrhage. It causes recurrent hemorrhage in the elderly. In unusual sites like lobar hemorrhages, not the basal ganglia hemorrhage. When you have a patient with the bleeding in the basal ganglia, you think of hypertension. When you have an elderly with recurrent hemorrhages in the various lobes, you think of amyloid angiopathy. When you have a young patient with abnormal site hemorrhage, you think of AV malformation. So remember, depending on the age and location, you will narrow down the diagnosis. Okay? Right. Coming to next one, the HIV drugs, important points here, which is the nucleotide T4T. It is tenofovir, which is also used for Hep B. And remember, this drug is nephrotoxic. Okay, this drug is nephrotoxic. Nevirapine, NENE, is used in the neonate, newborn. It is a NNRTI. Okay, it's a NNRTI. All your protease inhibitors are the navirs. So remember, abacavir is not a navir. Abacavir is a NRTI. Next one, entry inhibitor drugs are enfuvertide and maraviroc. Very, very important. Where does enfuvertide act? FF, it acts on GP41. Where does maraviroc act? In the man. It acts in the man wala receptor, konsa? CCR5. And remember, this is a very, very potential question for your INICT exam, which is the first kind of the HIV drug which directly binds to GP120. What binds to GP120? GP120 वाला drug कौन सा है? That is fostemsavir. Okay, remember, that is fostemsavir. Fostemsavir. This is your potential question for your exam. Remember, the HIV drug binding to GP120 is fostemsavir. This GP120 is the one which causes the invasion, the entry into the human cells, the CD4 T cells. Very good, Rashi. Fostemsavir. Very, very important. It is fostemsavir. Okay. And your tegravirs are integrase inhibitors. Okay, these are integrase inhibitors. They can cause myopathy, so CPK levels बढ़ेंगे, and also they can be hepatotoxic also, hepatotoxicity and CPK. Okay, myopathy. We have seen the side effects already. Nail pigmentation, zidovudin. Nail is like this, which is like a Z, zidovudin. And the palm, the skin pigmentation is emtricitabine. Vivid dreams is efavirenz. HLA testing is for abacavir. ICH, tip barsa khoon in the brain, is tipranavir. We have seen all of this. Indinavir is the stones, right? I hope all of you remember. Very good. Also remember the HIV monoclonal antibody, ibalizumab. Remember Bali mein jaake, right? All the illicit activities, Bali mein jaake, and it leads to HIV. So Bali wala drug is your HIV drug, ibalizumab. Okay, ibalizumab, that also acts on the entry. Okay, right. Coming to some other points here for the antiviral drugs that we have. The question that has been asked. So you can see the HIV, which is entry pe acting wale drug enfuvirtide, and you have maraviroc. Okay, so you have maraviroc acting maraviroc, and you have enfuvirtide. Then the HIV enters, there is reverse transcriptase, so NRTI, NNRTI. Then the integration happens, so dolutegravir, right? The tegravirs come, and then finally comes the protease inhibitors, all the navirs. Okay, all the navirs. Some other important antiviral drugs, remember, for herpes and CMV. What is the drug of choice for CMV? Remember, C is similar to G. For CMV retinitis, it is ganciclovir. And what is the side effect with ganciclovir? Bone marrow suppression, right? Bone marrow suppression. For varicella, for herpes, it is acyclovir. Remember, both of these are guanosine analogs, GAG. Guanosine analogs are acyclovir and ganciclovir. So they need phosphorylation, right, by the viral thymidine kinase. Viral thymidine kinase. पहले वो phosphorylate करेंगे, फिर cellular करेंगे. Now, if there is resistance to acyclovir, so you can give the drug which directly act on the DNA polymerase inhibitor. They do not need any phosphorylation. No phosphorylation, no activation needed for these drugs. So therefore, you can give in the resistance. So cidofovir and phoscarnate. These can be given when there is resistance. And remember, for phoscarnate, very, very important, CaCa calcium. It can cause hypocalcemia or other electrolyte abnormalities. Very, very important. Okay. Phoscarnate causes hypocalcemia and other electrolyte abnormalities. Ribavirin, which is used for both RSV and HSV, palivizumab for prophylaxis, ribavirin for treatment. Remember, ribavirin is a guanine nucleotide synthesis inhibiting drug. Okay, it's a guanine nucleotide synthesis. Remdesivir, which is used in COVID, remember R for R, it inhibits your RNA dependent RNA polymerase here. And remember, this is adenosine analog, that is ATP wala. Adenosine ATP का जो pro है adenosine, उसका analog है remdesivir. While you have baloxavir, which is used for influenza. Baloxavir, remember, bal on the cap. Cap, it inhibits the cap snatching activity of the influenza virus. Baloxavir inhibits the cap snatching activity. And very, very important, this is so frequently asked, your oseltamivir, zanamivir, remember, me drugs are acting on neuraminidase. What is the function of neuraminidase? The release. So they are basically acting on the release, inhibiting the release of the progeny oseltamivir and zanamivir. So if you are shown the virus cycle like this, remember the last step, that is the release, is your oseltamivir and zanamivir. Very, very important, right? This is very, very important. And I've told you few other important points also. And this does not need your activation. So you can use in cases of resistance. Ganciclovir is the drug of choice for CMV, right? And remdesivir is adenosine analog used in COVID-19. Okay. Which is, Which is the drug? Very good. Cidofovir is for recurrent respiratory papillomatosis also. And also remember that cidofovir is the drug which needs to be given with probenecid. With probenecid, cid is cidofovir. What drug do you give with probenecid? Is cidofovir. Okay, it is cidofovir. You need to give hydration and probenecid. Okay, important. Coming to next important graph that has been asked in your recent INI-CT exam also. So this is again a Dale's experiment, got the vasomotor reversal. This is the Dale's experiment showing the muscarinic and nicotinic action of acetylcholine. So in the nicotinic receptors, you have the NM receptor and NN receptor, NM on the NMJ, NN on the ganglia. So remember, acetylcholine by acting on the ganglia increases the blood pressure. So what are you seeing here is, this is the blood pressure effect by acetylcholine. The question asked is, this phase that you are seeing where the blood pressure is increasing is because of what receptor, what action of acetylcholine? It is nicotinic action. Acetylcholine first being a cholinergic drug, parasympathetic. Remember, it causes decrease in blood pressure because it decreases the heart rate, right? So you give low dose, decreases blood pressure, high dose decreases the blood pressure further. But when you give atropine and then you give acetylcholine, the muscarinic receptors are blocked. Remember, atropine blocks the muscarinic receptors only, not the nicotinic receptor. So when you give low dose acetylcholine here, atropine is blocking muscarinic. When you give still higher dose of acetylcholine, still under the influence of atropine, a higher dose will produce nicotinic effects and it will lead to hypertension. So this is what you need to understand for acetylcholine. Muscarinic decreasing, atropine किया muscarinic block हुआ, nicotinic block नहीं हुआ. Remember, atropine does not block nicotinic receptors. Okay, atropine does not block the nicotinic receptors. So there is going to be hypertension. So this phase 4 is because of the nicotinic receptor activation. Okay. Similarly, this is another diagram showing the Dale's experiment for acetylcholine. So blood pressure, you give acetylcholine, blood pressure decreases. You give atropine, then you give acetylcholine, no decrease in blood pressure. You give higher dose of acetylcholine, the blood pressure increases, and this is because of the NN, okay, the nicotinic ganglia stimulation. Okay, ganglia stimulation. Is this clear with everyone? Right? Okay. Going to this one, and what is this graph showing, guys? What is this graph showing? Very, very important. What is this graph showing? This graph is showing Dale's vasomotor reversal. Dale's vasomotor reversal. It is with which drug? It is with adrenaline, that is epinephrine. Okay, it is with adrenaline, that is epinephrine. Class jab tak ye finish hoga, we have few more slides to go. So we have anti-epileptics, hypolipidemic drugs, antifungal drugs, right, and some antiplatelet drugs. So kuch important topics baki hai. ठीक है? Yeah, actually, Vipin, that is how people used to be. I think now, because with all the digitization and gadgets, you know, our brain has become very atrophic. Tab jab kuch nahi tha, there were no social media distractions. So people in the old days, you know, they were more inquisitive, right, and more experimental. Whereas part 1, Vivek, I think you've joined late. I've already mentioned that part 1 of pharmacology binge revision and other subjects binge revision is on the Medsynapse app. Okay, it's happening on the Medsynapse app. So remember, vasomotor reversal basically is with adrenaline epinephrine. I hope you remember from our short classes that epinephrine acts on every receptor, alpha, beta, beta 1, beta 2, versus noradrenaline. Noradrenaline has no beta 2 action. That means it causes no vasodilatation. That means it causes no decrease in diastolic blood pressure. This again is your previous year question. Okay. So when you give adrenaline, epinephrine, so it is acting here on the alpha receptor and increasing the blood pressure, right? And then फिर beta वाले पे act करके the blood pressure comes down. When you give a alpha blocker, so what is happening? Adrenaline will not be able to act on alpha. It will only act on beta. Remember ABCD, alpha causes constriction, beta causes dilatation. So when the alpha is blocked acting on the beta 2, it will cause just vasodilatation. So when you give adrenaline, the blood pressure will decrease instead of increasing. So pehle it was increasing, now it is decreasing. This is the reversal that has happened. So this will be seen with an alpha blocker. So epinephrine after alpha blocker is what is the Dale's vasomotor reversal. When you block the alpha, the beta 2 action will cause vasodilatation and decrease the blood pressure. I hope this is clear with everyone. So Dale's vasomotor reversal is with adrenaline. Okay, adrenaline and alpha blocker. Okay. Coming to some important points for your anti-epileptic drugs. Again, this is very, very important, guys. Remember, when anybody is having epilepsy seizures, what is happening? The brain is very active. So what do we want? We want inhibitory neurotransmitter. Which is the inhibitory neurotransmitter? GABA. So basically, we want to increase the GABA, or we want to decrease the conduction in the brain, so that we are, basically suppressing the brain. So all the drugs that you see here, action potential ko inhibit karne wala. So voltage gated sodium channel important hai, action potential. So you have the drugs acting on the sodium channel. Phenytoin, carbamazepine, valproate, lamotrigine, all of that. What is also important here is the calcium channel, which helps and comes here in the degranulation, the release of the neurotransmitter. So remember GABA pentenoids. Remember GA. GA is CA. It is acting on the calcium channel. Ethosuximide. It is acting on T-type calcium channels. Valproate has various actions. It acts on sodium, it acts on calcium, it acts on GABA. It acts on various actions, right? So remember, this is calcium channel blocker. Then you have the SV2A receptor. Okay, so what drug is acting here on the receptor? So the vesicle ka receptor hai, not allowing the release. Remember, SV2A VV wala is levetiracetam. V2 is levetiracetam, important. Okay, levetiracetam is SV2A inhibitor. Then what happens here? You have AMPA receptor, you have NMDA receptor. So you have the drugs acting there also. Like you have parampanel is AMPA wala, right? Then you have the GABA A receptor. Remember, this is GABA A receptor. GABA is your inhibitory, chloride ka inflow karega. So the drugs which are GABA agonist, not antagonist, are your benzodiazepines and barbiturates, and also remember topiramate. Benzodiazepines, barbiturates, we know that these drugs act on GABA A. Okay. Now the GABA which is released, it is taken up. So GABA reuptake hoga. So GABA फिर degrade होगा by what enzyme? GABA transaminase gets converted into the degraded compounds. So remember, valproate is also your GABA transaminase inhibitor. It has multiple actions. Which is the other GABA transaminase inhibitor? Vigabatrin. Vigabatrin, GABA transaminase inhibitor. Gabatrin, GABA transaminase inhibitor. VI, it causes visual side effects, the visual field contraction. So remember, VV wale drugs, valproate and vigabatrin, both of them are acting on GABA transaminase, and this is something that has been asked in your NICT exam. Valproate acting on GABA transaminase. Okay, this is important. So look at this table here. Phenytoin, carbamazepine, they act on the sodium channel. Okay, they act on the sodium channel, phenytoin and carbamazepine. So you can similarly remember, like our yesterday's mnemonic, put Nivea cream, which was a mnemonic for PD-1 immune checkpoint inhibitors, phenytoin, sodium and carbamazepine. Important points here: phenytoin causes gingival hypertrophy, hirsutism, right? It can cause osteoporosis, folate depletion. Carbamazepine, CBZ is CBC monitoring is required with carbamazepine because it causes agranulocytosis. Which antipsychotic causes agranulocytosis? clozapine causes the count slow, right? So carbamazepine can cause agranulocytosis, aplastic anemia. Next one, remember gabapentinoids, they are GA acting on CA, so gabapentin pregabalin. Ethosuximide is calcium channel T type. It is used in absent seizures, ethosuximide. Valproate is various actions, sodium, calcium, and even GABA transaminase. We have seen for valproate, weight gain, alopecia, right, low platelets, so bruising is what it will cause, pancreatitis, PCOS, hepatotoxicity in children. All of this we have seen yesterday. Okay. Remember, valproate causes cytochrome P450 inhibition. Lamotrigine is again sodium channel, and remember with lamotrigine there is SJS. SJS is what occurs with lamotrigine. Levetiracetam is SV2A. This is the one which can cause neuropsychiatric symptoms. And topiramate again is sodium channel. Remember, topiramate causes weight loss and it can cause kidney stones and glaucoma. Topiramate causes stones. Topiramate affects the two eyes and causes glaucoma. So very, very important. Remember, stones and two eyes glaucoma. This is seen with topiramate. Okay, this is seen with topiramate and it causes weight loss. Important. So that was about anti-epileptics. Coming to your hypolipidemic drugs. Very, very important. So understand here in hypolipidemic drugs, the statins, they inhibit HMG-CoA reductase, which is basically for cholesterol synthesis, which is occurring in the liver, right? So from where is, how do they act is by inhibiting the HMG-CoA reductase. So they are not allowing the synthesis in the liver. So what will the liver do? If the liver is not able to synthesize cholesterol, it will increase the uptake of the LDL cholesterol in the liver. Okay, it will increase the LDL uptake in the liver. That is your statins. So atorvastatin, pravastatin, all of these, that is how they act. Remember, these statins are metabolized by cytochrome P3A4, and that is why the drug interactions are common with these drugs. We need to be careful of the drug interactions, right? And they are to be given at night because the HMG-CoA reductase is maximum active at night. Okay. So remember, these drugs increase the LDL uptake in the liver by inhibiting the synthesis in the liver. Next, niacin, important. Remember, niacin is a nice drug. It increases HDL. Niacin increases HDL. Important. It's a nice drug. Next to that you have fibrates. How do fibrates act? FF. Remember, they stimulate PPAR alpha, not PPAR gamma. Gamma is for glucose. That is your diabetes mellitus wale drug. Thiazolidinediones. Alpha is fibrate. Alpha, remember, is for fats. PPAR alpha is for fat. Gamma is for glucose. Okay. So fibrates, PPAR is your transcription factor. So it upregulates the LPL, lipoprotein lipase. What does lipoprotein lipase do? It causes your chylomicrons and VLDL Inca storage into the adipose. So it increases your VLDL and chylomicrons uptake in the adipose, and that is how. So fibrates will predominantly decrease what? Cholesterol or triglycerides. They will decrease triglycerides because they are acting on lipoprotein lipase. Very, very important. Integrating with biochemistry, insulin stimulates lipoprotein lipase or inhibits lipoprotein lipase. Again, your short ka mnemonic, tell me, insulin stimulates lipoprotein lipase or inhibits? Yes. Yes, AMTCL, remember, night mein dene padta hai except atorva and rozua. Remember, atorva and rozua are all-rounder. All round the day, they will act. So, all-rounder. Very good. So, all you have to remember is insulin loves LPL. Insulin hates HSL. So, L, L and HH. Insulin loves LPL. Insulin hates LPL. Tell me from biochemistry, LPL के लिए कौन सा apoprotein लगता है guys? Which apoprotein is required for activation of LPL? It is apoprotein C2. And that is why when this is defective, what happens? You get type 1 dyslipidemia, which is hyperchylomicronemia. Okay, hyperchylomicronemia, which will cause pancreatitis. Triglycerides increase leads to pancreatitis. Triglycerides increase, lactate and plasma, right? All that is biochemistry. I hope you remember that. Okay. Please do your short shot very, very well for all the exam, whether it's FMG, NEET PG or AIIMS, right? It's a must do for all the exam. So fibrates, remember, very important. They cause gallstones. This is what has been asked in your exam. Fibrates cause gallstones, and fibrates increase the myopathy caused by your statins. Increase the myopathy caused by statins. That is why statins and fibrates should not be given together. Okay, they should not be given together. This is acting on PPAR alpha. Coming to next one, niacin drug is inhibiting the lipolysis and it is increasing the HDL. So it has a nice effects. Which are the monoclonal antibodies used here in hypercholesterolemia? Remember, PCSK9 inhibitors. PCSK causes LDL receptor degradation. So it prevents that. So alirozumab and evolozumab. So Li and Lo. Aliro and evolo. So lipid wala Li, lipid ko zero karne wala evolo. Lipid zero, lipid lowering. Okay. So remember, aliro and evolozumab, these are used in your hypercholesterolemia. These are PCSK9 inhibitors. Next, the drug acting in the intestine. So when the cholesterol is absorbed from the intestine, which is a drug which inhibits that? It is ezetimibe. Okay, remember, this is ezetimibe, which is acting, ezetimibe is acting on the absorption, intestinal absorption. Okay, so EZO, it does enteric zero absorption. Enteric zero, it acts on the intestine or zero absorption karta hai. Enteric zero absorption. Then you have the bile acid resins, which will inhibit the bile acid reabsorption, right? So you have all the chole drugs. Cholesteramine, colsavelum, cholestipol. These are the bile acid resins. Okay, these are the bile acid resins. So I hope this is clear with everyone. Your statins, PCSK9 inhibitors reduce LDL cholesterol. Niacin increases HDL. Fibrates decrease triglyceride. Ezetimibe is enteric zero absorption. Okay, clear with everyone? Right, that is your transporter there. Coming to this, again, a previously asked question in the AIIMS exam. Classify, this is your class 1 antiarrhythmic. How do I know this is class 1, guys? Remember again the short mnemonic. Class 1 is sodium channel NN. So they are affecting this phase 0 and phase 0 of the action potential. So that's how I know this is class 1 antiarrhythmic. So now tell me the first one. This is class 1A, class 1B or class 1C. What class is this of antiarrhythmic? Class 1A, class 1B or class 1C? What class is this? Yes, very, very important, and I'll tell you a very easy trick to identify this graph. Right, so that you will pray that you get this graph in the exam. This is class 1A, B or C. Okay, so this is class 1A. And what class is this? What class is this one? Class 1B, 1C. 1A तो हो गया, तो अभी 1B है कि 1C है? This is class 1C, right? And this is going to be your class 1B. So this is 1A, 1B and 1C, right, Srishti? You'll thank me after this if I tell you the mnemonic to remember this. This is very, very easy. All you have to remember for 1A, the graph that you have goes above the normal action potential. So it is increasing the action potential duration. For 1B, this goes below, right? It goes below the normal graph, right? So it is decreasing the action potential duration. Okay? And it is your class 1C, which is constant, right? It is same like the actual action potential. It is not above, it is not below, right? So all you need to remember, 1A is above, 1B is below, and 1C is constant. Now logically thinking, blocking of what channels are you seeing here? Blocking of what channels in the repolarization? That is potassium channel blocking. So when you block the potassium channel, action potential duration increases, and that is how the QT prolongation happens, and that is how it causes Torsades de Pointes. So remember, 1A drugs, which is the other class which is potassium channel blocker, it is your class 3 drug. So 1A plus 3, which are potassium channel blockers. Okay? So it is above, below, and constant. Right? मुझे भी आज ही click हुआ ये mnemonic, right? This is very, very new from the farm, of my mnemonics farm. Right? Next one. It is constant. That means it is not causing any action on the potassium channel. That is why it is not affecting the repolarization. Next one, it is causing below. That means the action potential duration is decreasing. That means what is it doing? This is a potassium channel opener. Okay, this is a potassium channel opener. Right, so remember, this is how you identify class 1A, class 1B, and class 1C. And in that, which are the class 1A drugs? Queen of Egypt proclaimed 2 pyramids, that is dipyramids, disopyramide. Quinidine, procainamide, and disopyramide. These are class 1A, they'll cause Torsades de Pointes. Class 1B, lignocaine. Remember, lignocaine is lidocaine. So that is IDO, 1 though, that is 1B drug, is lidocaine. Class 1C is flecainide. Remember, flecainide is C. This is class 1C. And remember, this is contraindicated in structural heart diseases. The class 1C drugs are contraindicated in structural heart diseases. Okay? Right? And also remember these drugs, which is your quinidine, verapamil, amiodarone. These drugs are acting on the P-glycoprotein. The other name for P-glycoprotein transporter is MDR1. Recent INICT exam question also. What does the P-glycoprotein do? It causes the efflux of the drug. Okay, it causes the efflux of the drug. When it is absorbed, it causes the efflux of the drug, and that is how it is responsible for resistance as well. Okay, it's responsible for resistance. So digoxin is your P-glycoprotein related drug. Quinidine, by blocking this P-glycoprotein, basically it increases the toxicity of digoxin. So quinidine, amiodarone, verapamil, right, all these drugs act on P-glycoprotein. Okay, they act on P-glycoprotein. Correct. Coming to next topic, very, very important, antifungal drugs. Right, remember antifungal drugs. Before we go to antifungal, हम ये कल microbiology में भी करने वाले हैं. In the microbiology binge revision on the app, Medsynapse app, you have the beta glucan test, right? And you have the galactomannan test. This is very, very important. What is beta glucan for and what is galactomannan for? What is beta glucan for and what is galactomannan for? Beta glucan is positive in all the fungi except negative where? Where is it negative? It is negative for Cryptococcus because it is a yeast, and it is negative in mucor also. Okay, it is negative in mucor as well. So it is negative for crypto and mucor. And galactomannan specifically is for invasive aspergillosis. Okay, this is positive in invasive aspergillosis. Please remember this point, very, very important. Okay, right. So what do we see here is, so you have candin, right? Echinocandin drugs. You have amphotericin B, you have flucytosine, you have azoles, and you have terbinafine. Let us see where do they act, because it's very, very important for your exam. So fungal cell, it has the cell wall, it has the cell membrane, and this has a nucleus. So first tell me, in the nucleus, nucleic acid synthesis drug is flucytosine. The terms itself tells you cytosine ke jaisa cytarabine जैसा, flucytosine will act on the nucleic acid synthesis. Next, you have squalene, which forms squalene epoxide, which forms lanosterol, ergosterol, and then it is going in the cell membrane of the fungus. So this is ergosterol important, right? So remember, squalene to squalene epoxide. Which drug is inhibiting the squalene epoxidase? It is lanosterol synthesis में terbinafine. So remember ST. Squalene epoxidase is terbinafine. ST. PQRST. So squalene वाला terbinafine है. Next आता है lanosterol to ergosterol. The enzyme here is 14 alpha demethylase. This is inhibited by azoles. Okay, this is inhibited by azoles. So all the azole inhibit the ergosterol synthesis. Azoles inhibit ergosterol synthesis. Terbinafine inhibits lanosterol synthesis. Okay. So clotrimazole, fluconazole, all of this, itraconazole, ketoconazole, remember all these are your ergosterol inhibitors. Then you have in the cell wall where you have echinocandins, right? Glucan जो हमने बोला जैसे होता है beta glucan in the cell wall. So echinocandins. So you have Anidula fungin, caspofungin, mica fungin. Candins are the fungins. Okay, candins are the fungins. सेल मेम्ब्रेन की इंटीग्रिटी को जो इनहिबिट करता मतलब अफेक्ट करता है, फॉर्मिंग द पोर्स इन द सेल मेम्ब्रेन. Remember, polyenes drug form the pores. Which are the polyenes? Amphotericin B. Remember, amphotericin polyene causes the pores. Very, very important. And so is nystatin. Okay, so is nystatin. Remember, nystatin, it is used for oral candidiasis also. Okay, oral candida. So amphotericin B is a broad spectrum antifungal. It has nephrotoxicity. So by liposomal amphotericin B, we decrease the nephrotoxicity. Okay. Does amphotericin B cause hypokalemia or hyperkalemia, guys? Very, very frequently asked. It causes hypokalemia or hyperkalemia? Very, very important. Amphotericin B causes hypokalemia or hyperkalemia. Yes? Remember, amphotericin B, A for A, causes RTA type 1, and in RTA type 1, RTA type 2, it has hypokalemia. Okay, we get hypokalemia. So it causes hypokalemia because it causes RTA type 1. Okay, it causes RTA type 1. So I hope you are clear with the mechanism of action of antifungal drugs. No doubt here in the antifungal drugs. Which is the antifungal drug which increases the absorption, increases with the fatty meals? Remember, fat is like grease. So what increases the absorption? Greaseofulvin absorption increased by fatty meals. Greaseofulvin causes disulfiram reaction. It is used in dermatophytosis like Tinea capitis. That is the drug of choice. What drug do you use in cryptococcal meningitis? Amphotericin B plus, flucytosine. In the maintenance phase, then what you use? You use fluconazole. Fluconazole for maintenance because it has a good blood-brain barrier crossing property. The azole with the blood-brain barrier crossing. Which one causes your gynecomastia? Gynecomastia, ketoconazole. Right? Ketoconazole causes gynecomastia. It inhibits your cytochrome P, inhibits the steroid hormone synthesis. So gynecomastia is seen with ketoconazole. ठीक है? What is the drug of choice for invasive aspergillosis? A का उल्टा होता है V. Remember, voriconazole is for aspergillosis. What is the drug for mucormycosis? Which azole for mucormycosis? Posaconazole. Okay, it is posaconazole which is for mucormycosis. All these are the questions asked in the exam. Okay, very, very important. And I think this is the last topic and this will be done finally. Pharmacology binge revision. Please revise this very, very well with your short shot. The PYQ discussion in the Medsynapse app, both FMGE and AIIMS, and your the binge revision, right? This will cover majority of your pharmacology for all the exams. For your AIIMS particularly, complement this with the new drugs video. which is there in app and on YouTube also. A separate video is there. Very, very important. Okay. Coming to the antiplatelet drugs, one we said is aspirin. What dose of aspirin is antiplatelet? Low dose. Okay, that is low dose. Cyclooxygenase, this is irreversible inhibitor, non-selective. So aspirin, by inhibiting cyclooxygenase, inhibits the thromboxane A2 synthesis from arachidonic acid, right? So one is aspirin. Next is you have your ADP receptor PTY12. That's basically the ADP receptor wala. So you have the P2Y12 inhibitors, clopidogrel, prasugrel, ticagrelor, cangrelor, and also ticlopidin. So remember all the grel wale drugs. Okay, the grel wale drugs. So remember the grel wale drugs are your P2Y12, and like clopidogrel, even ticlopidin. Even ticlopidin is your P2Y12. Remember the interaction of clopidogrel, very, very important, with omeprazole. You should not give it with omeprazole. There will be clopidogrel failure. Okay. Next, what we have is very, very important, the drugs which act on GP 2B 3A. 3A or 2B pe act karne wala, that is AB wala drug, apsizimab, tirofiban, eptifibatide. So AB या BA आएगा जिसके spelling में. You have apsizimab, tirofiban, eptifibatide. AB या BA वाले drugs, these are going to be your GP 2B3A. The Fib wale drugs, because remember fibrinogen is what is responsible for platelet aggregation. So very, very important. Apsizimab circulation में करने वाला GP2B3A inhibitor. Very, very important. Okay. Then you have the PAR1 inhibitor. This is your INICT exam question. Varapexar. X matlab inhibiting, PAR. PAR inhibiting drug is your Varapexar. PAR1 inhibitor, that's basically your thrombin receptor. So PAR1 inhibitor is Varapexar, right? Then what you have is phosphodiesterase inhibitors. Phosphodiesterase inhibitors will increase the cyclic AMP and inhibit the platelet aggregation. So remember, what do you have here? Dipyridamol, cilostazol, and trifluzal. Dipyridamol, cilostazol, C for third alphabet. Phosphodiesterase 3 inhibitor. CICI also helps in circulation disorder like peripheral vascular disease because it causes vasodilatation also. So cilostazol is circulation, peripheral vascular disease also it is used. Phosphodiesterase 3 inhibitor. So dipyridamol, cilostazol, and trifluzal, these are your phosphodiesterase inhibitors. So remember, all these antiplatelet drugs are important. In our short, we have already discussed your factor 10A inhibitors, difference between heparin and warfarin, direct thrombin inhibitors, right? Tranexamic acid, EACA, antifibrinolytic drugs. We have discussed all of that. Please complement this with that anticoagulants that we have discussed in the short. Right? So yes, this completes your pharmacology binge revision. Thank you so much for joining in here for pharmacology binge revision. Finally, it is done. Tomorrow, that is 4th of May, we have 2 binge revisions. That is microbiology and FMT. Microbiology at 12 noon, FMT at 3 noon, and both of these will be happening in app live for the subscribers. So please do join in there on the Medsynapse app. That's for subscribers. And for anybody, this is a timetable we have for the binge revision before your INICT exam. We will do the short binge revision for NEET PG and FMGE also after the INICT exam in app, right? So by 14th, we shall be able to complete all the binge revisions. And apart from that, for anybody who wants to be a member of the Medsynapse family, these are the various subscriptions that we have. As your well-wisher, I would definitely say that even if you are at this point of the exam preparation, that is your last phase, still use the Medsynapse short videos, binge revision videos, because they will help you to remember the most important stuff, the most volatile stuff, which you cannot make wrong in the exam, right? So don't be afraid of like, how do I start a new resource? This is going to complement your already resources that you are using. You will learn a lot of tricks and mnemonics to remember the difficult topics. Okay. So thank you so much, everyone, guys, for joining in. And I'll see you again tomorrow at 12 noon and at 3 noon for your microbiology and FMT. Yes. Yes, Pradeep. Intermittent claudication. Absolutely right. Right. Remember the grillors, wherever you have grillor, OR is temporary. OR is temporary inhibitor. Okay, that is temporary inhibitor. Okay. Duration of the class tomorrow, duration mat pucho yaar. Microbiology will be somewhere around 2 hours itself. Right. And then we'll try to wrap up FMT in like 1 to 1.5 hours. Right, so see you everyone tomorrow on the Medsynapse app for the binge revision of microbiology and FMT. Till then, goodbye, take care, keep studying, keep revising, keep Medsynapsing, and keep winning. Thank you so much.